Introduce the opposition Shadow Minister for Health, Catherine King, who is here for a short time. It's a busy day in Parliament today, so that's why there's a bit of sort of swapping around of things, but we're very grateful for all of the politicians to make time to come and talk to us today. It's absolutely fantastic to have all of you here. So please welcome Catherine King.
Thanks very much for that, Sophie. And can I start by acknowledging the traditional custodians of the land on which we gather, and I pay my respects to their elders, both past and present. I'd firstly like to acknowledge the Mary MacKillop Institute for Health Research for your work, not only in producing the Hidden Hearts report, but for your ongoing research and advocacy around improving access to health services and ultimately improving health outcomes in our society. And I would also like to acknowledge the terrific work of the Heart Foundation, who over many, many years have been assiduous in raising the lack of investment in cardiovascular disease, but also in women's cardiovascular disease for a long period of time. To my parliamentary colleague, Senator Richard Di Natale, and I understand Minister Lee was here beforehand as well, so I acknowledge that she was here. And I think the Secretary of Health was here as well. I've got on my list, but I can't see him in the audience here. The speakers before me have covered some of the frightening statistics around why cardiovascular disease at risk and disease is such a pressing public health challenge, so I don't want to revisit that here this afternoon. However, I do want to highlight a couple of statistics that absolutely stood out for me. The fact that coronary heart disease continues to be the leading specific cause of death in Australia, and cardiovascular disease is the second highest contributor to the burden of disease in Australia. That 1 in 5 Australian adults have at least one cardiovascular disease, with prevalence similar for men at 20% and women at 22%. But most importantly, in the context of today's conference, the recent Jean Howells Women's Health Study of 2016, which found that cardiovascular disease was not rated in women's top 5 health concerns. So there's a clear challenge facing researchers, clinicians and policymakers of cardiovascular disease continuing to be a leading cause of death for both death and burden of disease in Australia, impacting both men and women. But there is a worryingly disconnect between these statistics and what women identify as their main health concerns. The task for the broader health community is to develop policies that not only ensure that the community is more aware of chronic diseases, but that individuals are empowered to take positive steps to prevent them. We know that the social determinants of health must underpin future health policy if we are to overcome the persistent inequality gap which exists in health outcomes. It is estimated that between 1/3 and 1/2 of the life expectancy gap may be explained by differences in the social determinants of health. This is particularly important when it comes to chronic disease, including cardiovascular disease. Studies have shown that increased social inequality translates to prevalence of cardiovascular disease, and it is well established that people who are socioeconomically disadvantaged experience higher rates of cardiovascular disease mortality than other Australians. The Australian Institute of Health and Welfare found that the most disadvantaged Australians aged 25 to 74 years experience significantly higher mortality and hospitalisation rates from chronic conditions than the least disadvantaged, including cardiovascular diseases. And we know that people in the most disadvantaged socioeconomic group are more likely than people in the least disadvantaged socioeconomic group to have modifiable risk factors for CVD, including smoking, insufficient physical activity and poor nutrition. A holistic approach to health reform must address social determinants of health and health inequality. As a society, we cannot afford, and our health system simply cannot afford, to just gasp at these statistics around cardiovascular health, but then disengage with the policy efforts which are required to make a change. Everyone in the room knows that relatively small evidence-based investments by governments can reap huge health benefits. We know that national leadership on crucial health protection, prevention and promotion is critical. I know the decision to spend money on preventative health is not an easy one for governments to make, but our ageing population demands a long-term commitment to preventative health, not only for the savings to health costs, but for the improvements in health outcomes for Australians. And one of the key challenges we face is reforming primary care to meet the changing needs of an ageing population with rising rates of chronic disease. That all comes back to prevention. At a time when the growing cost of healthcare is in the spotlight time and time again, investment in prevention does make sense. Socially, it is also good fiscal policy, and that is an argument I will continue to make within the shadow ERC. With this in mind, I'm very proud of the prevention policies Labor took to the election, which showed our strong commitment to public health. In particular, I want to highlight our commitment to Australia's first national physical activity strategy to get all Australians moving more. We have also identified 50 communities where chronic disease and risk factors that drive it are greatest, and invested specifically in them on the basis of a policy that's been very successful in Victoria, the Healthy Communities or Healthy Together Communities policy. Our package also included other measures to prevent the problems GPs see every day, like a renewed campaign on tobacco and a new national alcohol strategy. There are three particular challenges facing those here today. The first challenge is researching and understanding the burden of cardiovascular disease in our community, to which Hidden Hearts and the Mary MacKillop Centre play an important contribution. The second challenge is addressing this burden and implementing policies which will make a difference. The third challenge is clearly overcoming the myth that heart disease is a man's disease. The Hidden Hearts report shows that this is clearly not the case. No amount of research or public policy action will be effective if women do not consider or understand that they are equally at risk of cardiovascular disease. A female cannot see a poster about heart health and think it is only a conversation she needs to have with her partner. Armed with a clearer picture of the way women underestimate the threat of heart disease plays in quality of life, we now all have a responsibility to act on it, and I will continue to push for strong political leadership in this area. But governments and politicians, of course, can't do it alone, and we need a strong partnership with experts, with researchers, with clinicians and community workers to make a real change in this area. I look forward to working with you on that change. Thank you.